We are live.
Yes, good evening, everyone. I welcome you all from my bottom of my heart for this oncology update of day 2 on breast oncology. As we know that as we know that even in the stage there is a lot of advancement has taken place in the treatment of carcinoma breast, and even in the metastatic breast cancer, we know that people lives up to 8 to 10 years together. So today's session is, focusing on the. We will focus on what are the advancements in the setting the treatment of carcinoma breast cancer. About the molecular biomarkers in the yeah. Yeah, please put it on. Yeah, yes, Dr. Ankush. Now it's clear, Gitika? Gitika,
Yes, sir.
is it clear now?
Yes, sir. Your voice is audible.
Okay, okay. Let's start with Dr. Ankush. Please tell her to share her slides. Ask her to share her slides, please. Gitika, share her slides, please.
We have
No.
a slide.
Sure, sir. We'll share. No, no, Dr. Ankush is not audible, ma'am.
Dr. Ankush, you can rejoin. Just try once. She's not audible.
Dr. Ankush is rejoining, ma'am.
Yeah, sure.
Gitika, meanwhile, you can call the remaining speakers, please.
Sure, sir.
भाई तू ज्वाइन कर ले भाई. अरे तू कर दे भाई लॉगिन. हमारे तो दिल की धड़कन बढ़ने लग रही है भाई. मैं कहा भाई नहीं ज्वाइन करेगा तो कौन करेगा भाई. कर भाई. Yes. Good evening, Dr. Ankush.
Good evening. Good evening. I'm so sorry for all this network issue that's going on. I have logged in from a separate device now. I hope I'm audible this time. Hello. Am I still not audible?
Yes. Yeah, you are audible, ma'am. You need to share your
Am
slides.
I audible? Okay.
Yes, ma'am.
Thank God.
Yes.
Thank God. Okay.
Ma'am, your slides are visible. You can go ahead.
Okay, so how do I change the slide?
You just need to say next. Ritika.
Okay, right. So, hello everyone. This is Dr. Ankush. I am pathologist. First of all, I would like to thank Dr. Deepak to give me this opportunity to speak on this topic, which is molecular biomarkers in breast cancer. Next slide, please. Right. So breast cancer is one of the most common type of cancers in females in India. And conventionally, we have classified breast cancers into different types based on its morphological features, histological features, the grade of tumor, proliferation status, and lymphovascular invasion, and morphological features like that. However, these days, there has been a shift to classify the breast cancers based on their molecular signature. Next slide, please. Now, what exactly is meant by a molecular marker? What do we understand by that? So, molecular marker is something which can be objectively measured in laboratory, and it is used as an indicator of the pathogenic processes or how the pharmacological response to therapeutic intervention would be there. So, what is happening here is the tumor cells or the cells of the body, they express genes in form of various proteins, and these genes, these proteins, they can be measured in the laboratory. Now a particular cell or type of cells, how much quantity of that protein is being produced by those, that can be measured in the laboratory, and that can be used as an indicator of what processes are going on in that cell, if it is a tumor cell or not, or if it is a cell, what kind of response is expected out of that cell if we provide therapy to that kind of tumor. So that is meant, that is a molecular marker. Next slide, please. Why do we need to do molecular testing in breast cancer next? So basically, we need to do molecular testing in breast cancer. First of all, classify the tumor types. Now, these days, the classification of breast tumors is not exclusively based on the origin of tumor, but it is based on the molecular signature of the cell. We'll come to that part later. Apart from classification of tumor, we also need to recognize the hereditary implications. Now, breast tumors are a part of familial cancers, so we need to study those genes which can be passed on to the progeny, and there is a risk of development of cancer in along the family lines. Next, we have certain therapeutic agents that have been developed against specific markers, specific proteins, specific receptors on the cells. And these therapeutic agents shall act only if the expression of these particular targets is there on the cell. So we need to evaluate the cells for presence of those targets. Also, we need to determine the prognosis of the disease. And so the various risk scores which have been devised, they are also based on the molecular markers of breast cancer. Apart from that, for monitoring the response to therapy, for that also molecular markers are being used. Next. Now, the first molecular classification system used only HER2 new receptor, which predicts the response to hormonal therapy and anti-HER2 therapy, respectively. However, these days we have incorporated a large number of molecular markers in the classification as well as use in treatment of breast cancers. Next. Now, this is the classification. All of us know this about the molecular classification of breast tumors. Just to brush up, we know that breast tumors are luminal A, luminal B, HER2-neu, and basal-like. Now, the basal-like has also further been classified, but for scope of this lecture, I have kept it a little bit short. So, just to summarize, so luminal A, luminal B, HER2, and basal-like, these four types are there. So, luminal A is most common type. Basically, these are hormone receptor positives, and that hormone receptors, that is ER/PR positive, and HER2 is negative in these tumors. Luminal B, on the other hand, will have variable expression of HER2 new, ER/PR will be positive in both luminal A as well as luminal B. HER2 new, third category, the HER2 new. This one is characterized by positivity of HER2 new receptor. The last category is basal-like. It is also known as triple negative, in which these three, ER, PR, and HER2, all are negative in this. Now, if we come to the prognostic implications, luminal A, they are regarded as to have better prognosis compared to remaining. Luminal B is not as good as luminal A. HER2 new and basal-like are not regarded as good prognosis. Next. Right. So, why do we need to classify tumors into luminal A, B, HER2, and basal-like? Because we can predict the response of therapy and what kind of therapy should be given to these tumors. Now, luminal A and luminal B, basically, they respond well to hormone therapy. HER2 has a special drug developed against it, which is trastuzumab. So, presence of this receptor indicates the use of this particular drug. Basal-like indicates that basically, these drugs, endocrine therapy and trastuzumab, are not going to be responsive, very well responsive to these kind of tumors. So prognostically, I've already told luminal A has one of the best prognosis. HER2 and basal-like, they don't have such good prognosis. Next, please. Now, where does the role of pathologists come in all this? So, apart from classification, traditionally the involvement of pathologists was only in diagnosis and classification. But these days, the role of pathologist is evolving and it is increasing. So now we need to advise what kind of testing needs to be further done after the diagnosis, what kind of molecular markers should be evaluated in the patient after the treatment is started, how to monitor the treatment. In all these aspects, the role of pathologist plays a part. Next, please. Right. So I already told, like, molecular markers are the proteins, are the receptors which are expressed by the cells, and they are measurable. We measure them, and from that measurement, we make a prediction of how the tumor is going to respond and about what treatment be given to that particular patient with that tumor. So there are certain well-established markers in case of breast cancers. So for every case, it is recommended that these should be evaluated. If not all, the first three, they must be evaluated in every new diagnosed case of breast cancer. So these are, the first one is hormone receptors, second one is HER2, which is human epidermal growth factor receptor, then is Ki67 antigen, and then three. And then we have two genetic markers, which are BRCA1 and BRCA2. Next. So we'll talk a little bit in detail about each one of them. So the first one are hormone receptors. So the best studied hormone receptors in case of breast cancers are estrogen receptor and progesterone receptors. So these are normally also expressed in epithelium of breast. So the expression of ER and PR basically in a tumor cell means that as these are expressed in normal tissue also, if their expression is carried on in the tumor cells also, that means that the differentiation is good, right? So they are more like normal cells. So the response to the therapy is going to be much better in case of a hormone receptor positive tumor cells. This, apart from the fact that we have a drug, which is tamoxifen, which specifically blocks this receptor and provides anti-estrogen and anti-estrogen effect to the tumor cells and causes tumor rejection. Apart from that, the presence of case of breast tumors. So tamoxifen was the first drug, one of the first drugs which provided anti-estrogen therapy, which it targeted the estrogen receptors. So it was observed that it resulted in clinical remission in patients with breast cancers which are positive for estrogen receptor, right? So the tumor cells expressing hormone receptors have better response to hormone therapy. And so when we have to take a decision decision about use of hormone therapy in case of breast cancer patients, evaluation of these receptors becomes imperative. Next, please. The next very important marker is HER2/neu. So HER2 is a transmembrane tyrosine kinase receptor. So this belongs to family of receptors called EGFR receptors. So this particular the protein for synthesizing for this receptor is located on chromosome 17. So chromosome 17q21, this is the location. So this is important. We'll come to that a little bit later. So amplification of this particular protein is observed in about 20% of cancers. And this is considered as a marker of poorer prognosis. Despite that, we have developed a specific drug, this is trastuzumab, which acts against this particular receptor. So the point here is that these cancers may not be curable, but they are treatable. So it is not like no treatment is available if this comes negative. But however, this if this comes positive, but prognosis is bad. You can start treatment. However, ultimately, in the long run, the prognosis is not as good as those for which ERPR is positive. Next, please. Next is Ki-67. This which is produced by the cells which are multiplying. This is not produced by the cells which are in resting state of cell cycle. Only the cells which are dividing or multiplying, they will express this particular antigen. So what's the role of this antigen, not only in breast cancer, but in almost all the tumors, is that more there will be the Ki-67 index, more are the number of actively multiplying cells in that particular tumor. This is also known as proliferative index because it indicates that how many cells are proliferating at that time in that tumor. So this is expressed as a percentage. So Ki-67 positive percentage of cells are the number of cells, are the percentage of cells which are multiplying, which are in active state of multiplication at that particular time. Next, please. Next is P53. So P53 gene is known as guardian of genome. This particular gene basically is not directly involved in development of breast cancer, but the thing is this gene helps to repair any damage to the DNA which happens. If there is a mutation of P53, this indicates increased susceptibility to development of cancer, number one. Second thing is breast cancers are regarded as a heterogeneous group of cancers. This means that not only there are many types of tumors population in a same tumor, of cells with multiple signatures. So if we see at any particular time, some of the tumors, they will be very well responding to therapy, but they will have some group of cells which will not be responding to therapy. So it's a heterogeneous population. So this particular mutation uh, it indicates bad prognosis, and it indicates that more number of populations are going to be present in that particular tumor. So how do we check for this marker? Like ERPR HER2/neu, this is also tested by immunohistochemistry. We'll come to that a little bit later. Next, please. Now, unlike HER2/neu, this one is P53. Despite, we know that this has prognostic implications, we don't have any drug or therapy which is directed specifically against that. Despite that, it needs to be evaluated so that we can get an idea about the prognosis of the patient. After that, the two genes which have become really important these days are BRCA1 and BRCA2, BRCA1 and BRCA2. So these need to be evaluated in cases of breast cancers as well as ovarian cancers. So why do we need to evaluate this? So it has been observed that in case of tumors, BRCA1 or BRCA2, they tend to come out to be positive. However, in case of sporadic tumors, it is almost never positive. So why do we need that? So if there is a female who suffers from breast cancer and has been evaluated for these two and come out to be positive, now the sisters and the daughters, they should also be get evaluated for this particular mutation, because if found to be positive in these, then they can take timely prevention, they can take counseling, they can even go for prophylactic mastectomy and oophorectomy or chemo prevention. All these things can be can be undertaken in such females even before the development of tumor is there. Next, please. Now, the 5 markers which I previously talked about, they are the common ones which we are using routinely. These are certain new markers which are under development. These include TCM, which is CXE, chemokine receptors, and certain factors like EGF, HGF, transforming growth factor beta, etc. But these are all under research, and various therapies are being developed under these receptors. Next, please. Now, what is meant by gene expression profiling? So, all the of the genes, and these genes, they express in form of proteins. So these proteins, they can be detected by various means. The genome of a tumor cell is expressing in form of certain proteins, and evaluation of these proteins is called profiling, right? So gene expression profiling. So how can we do that? Various methods that can be used for evaluation are immunohistochemistry, FISH, which is fluorescent in situ hybridization, RT-PCR, gene microarray, and next generation sequencing. Next. Immunohistochemistry is the most common way in which we are doing that, not only in case of breast cancers, but in most of the other tumors. So what exactly is immunohistochemistry? In this, we are using antibodies to detect the level of a specific protein. So like I told you, the nucleus expresses, the genome expresses certain proteins, and these proteins will be present at various levels. They can be present in the cytoplasm, they can be present at cell surface, they can be present at the nucleus. What we are doing basically is we are using antibodies against these proteins, and these antibodies, they join these proteins, and then they are observed microscopically for the presence of these proteins. So what is the sample that is used for this test? So we use formalin fixed paraffin embedded uh, tissue for this. Next. Next, please.
Geetika, next slide, please.
Hello.
Next slide, please. Next slide.
Yes, ma'am. Yes, ma'am.
So we are done with this. Next one, please. These are the basic steps. Can we go to the previous slide? Yes, so these are the basic steps for immunohistochemistry. So what we are doing is the fixed tissue is taken, you cut sections out of it, which antigen goes to the protein which we want to test. So that antigen is retrieved, it is stained, with the help of a primary antibody, and then this protein is it gets bound to the primary antibody. Now this complex is tested by using a secondary antibody, which is also known as DAB antigen. This second antibody is coded, right? So this produces a specific change in which is observed under the microscope. So next, please. And that is how we detect the presence of these proteins in. Next slide. What are the advantages of immunohistochemistry? Expensive procedure. So processed slides, they can be stored for a long time. It is done. You don't need special equipment. Some of the cancers, they can persist for years together. If an old record needs to be reviewed again, the slides can be taken out and reviewed again. However, as we'll come to the scoring, we will know that this is a very subjective evaluation. What appears as 1 plus to me may appear as 2 plus to someone else. So there is no set rule for evaluation, although subjective evaluation. There are a number of factors that can affect the result. A fixation time can affect the result. What kind of reagents you are using, that can also affect. Another disadvantage is, which is very that use only 1 to 2 proteins per section. So the thing is, more and more tumors are now being evaluated by core biopsies, and core biopsies have a limited amount of tissue. Now, if you want to evaluate for, let's say, 10 or 12 markers, it's just not going to be possible because the tissue is going to get finished. So you can test only a number of markers on a particular section. And if the tissue is less, you can only check for a number of markers. Right. Next, please. So, of all the molecular markers that I have told, which are the ones which can be tested by immunohistochemistry? So, hormone receptors, which include HER2/neu, these are commonly tested by immunohistochemistry. That and Ki67. Now, if we come to HER2/neu receptors, they can only FISH, which is fluorescent hybridization, and chromogenic. But more commonly, it's not needed hormone. When it comes to HER2/neu, this might require for FISH and chromogenic. Next slide, please. So this is the scoring system for ERPR, for hormone receptors. So the score is calculated based on proportion and intensity. Proportion refers to the percentage of cells which have taken up the stain, and intensity refers to how dark the stain is. Right. So this is a set score, and the total score is calculated. And if the score is less than
Dr.
2,
Ankush?
it is regard. Yeah.
Hello.
Hello.
Please conclude your talk in next 2-3 minutes. Hello.
Okay. Okay. Right. So next slide, please. Let's finish it then. So this is just an image which shows the ER and PR positive. Next, please. How to new scoring, on the other hand, we see that there is a particular category which is called as 2, right? So this particular category is equivocal. This does not help the clinician very much. If we either give negative or positive, it is beneficial. But if the result comes out as equivocal, then it is not very helpful. So in such cases, one has alternative method, which is by FISH and Kish. Next, please. So this is an example of HER2 positive tumor. Next. So fish is fluorescent in situ hybridization. What we are doing in this is we are using a fluorescent labeled probe. So the DNA is denatured and this fluorescent labeled probe, which is to detect a particular mutation, this is added to the sample. And if that mutation is present, this probe binds to the sample and produces a fluorescent signal, which can be detected by uh, microscope. And we come to know if the particular mutation is present. This is just an image indicating principle of fish. Next. Next, please. Next slide. So this does have high sensitivity and specificity, but this cannot be used for all the patients because each probe of fish is very pricey, and you can only detect a single mutation per probe. You cannot analyze a number of mutations. So there are two types of analysis which can be done on a HER2 news. One is single color fish, which is only for HER2 gene. And second is dual color, in which we are not only detecting the mutation, but we are also detecting the CEN17 chromosome 17 centromere mutation. The gene itself may not be mutated, but if the centromere is mutated, the gene does not become functional. So it is recommended that both of them should be evaluated. Next slide, please. So this is an indicator indicating of HER2 new increased expression by fish. Next, please. So this is dual color fish. What we are doing here is the brown color is indicating the HER2 receptor, and the pink color that is indicating the centromere. So overexpression of HER2 will lead to multiplication, more number of dots, more number of brown color dots, as can be seen in image B. And if there is loss of centromere, then there will be loss of that pink dot. Next. So this is dual color fish. Next. The next technique which can be used for evaluation is gene microarray technique. In this, what we are doing is we are denaturing the whole of DNA of the tumor cell. So next slide, please. I'll directly tell the next slide. Right. So what we are doing is the whole previous slide. Please show the image. Yeah. So what we are doing is the whole of the genome, it is denatured and the RNA is extracted. So we take a control sample and we denature that also. So what's basically happening here is if there will be a mutation, so this these denatured proteins, these denatured RNA, this is going to be different from the normal one. And when you hybridize them, so the way these bind is going to be different in case of tumors. So the advantage of this is that you can analyze the whole genome in a single test. Next. Next. So the advantage is it can predict the behavior, how the tumor is going to behave. But the disadvantage is the initial probes that we are using. The sensitivity depends on the those probes. Now the last method is which is becoming increasingly popular these days is next generation sequencing, the next generation DNA sequencing. So in this also we are analyzing whole of the genome, but we are not using any probes to bind to these denatured proteins. So what we are doing is, next slide. So basically what we are doing is similar to microarray. The whole genome is denatured, but in microarray we were using probes to detect those segments. Here we are not using any probes. Here we are breaking down the DNA into various fragments. Now, if there will be mutations, the size of these fragments, the type of these fragments is going to be different. So then we amplify these fragments produced by various means, and we analyze these fragments. So based on the fragments produced, we are able to generate like what the original genome was. and we can detect the presence of mutations in that. So this is different compared to a microarray. In that, we were using probes to detect the sequences. Here, we are not using any probes. We break the DNA, we amplify the DNA. We amplify the DNA so that the signal produced is it becomes detectable, and based on the signals produced, we match it with the library, and then we can predict that what mutations were present in the sample. Next, please. So there are a number of advantages of next sequencing. Next slide. So this is a single test in which the whole genome can be evaluated. So that is the big advantage which is with this particular test. However, we also have testing for specific targets of the genome. Like if we want to evaluate only for BRCA mutations, we can do that also. So next please. So, in conclusion, molecular testing is becoming increasingly important. So these days, breast cancers need not be evaluated only on basis of morphology or histology. Molecular classification and these molecular markers, they are becoming increasingly important for not only predicting the biological behavior of these tumor cells, they also help in guiding the therapy, they also help in predicting response to therapy, and of course, they help in providing the prognostic value to the patient. That's all. I conclude my talk. Next slides are just my references. Thank you so much.
Thank you, Dr. Ankush, for this fantastic talk and for enlightening us
Thank you, sir.
for new molecular biomarker for carcinoma
Thank you,
breast.
sir. Thank you for giving me this opportunity. I
Yes.
appreciate.
Yeah, thank you so much. So our next speaker is yeah, thank you so much. Yeah, and hopefully we will be seeing a as we know that molecular biology of breast is still evolving, and we hope to see the new molecular biomarkers in future as well. Yeah, thank you so much, and for enlightening us about the molecular biology of breast cancer. Gitika?
Sir, for the next speaker is Dr. Prashant.
Yes, yes. So our next speaker is our dear friend Dr. Prashant, who is a professor at Mahatma Gandhi Medical College, Jaipur, who will be telling us about the uh, what are the other options for new SCRM and what are the recent advances in the new SCRM. So Dr. Prashant, over to you.
Thank you, Deepak sir, and I thank you very much for giving me this opportunity to present two recent advances in metastatic breast cancer, hormone receptor positive. So I'll discuss briefly about two recent advances. So first is Emerald trial of elacestrant versus investigators' choice standard of care endocrine therapy. Please share the slide. Please share the slide. Next one. So this is the phase 3 randomized control trial, elacestrant versus investigators' choice standard of care ET in hormone receptor HER2 negative metastatic breast cancer. So it has been randomized between two arms, elacestrant 400 milligram versus standard of care investigators' choice like fulvestrant, anastrozole, or letrozole, or exemestane. The eligibility criteria: man and postnatal woman with ER positive, HER2 negative, metastatic breast cancer, relapse or progression of disease after 1-2 lines of ET, with 1 line with CDK4 inhibitor, less than or equal to 1 line of CT4 advanced disease. So therapy was given until progression of the disease or unacceptable toxicity. And primary endpoints: PFS in all patients, as well as PFS in all ESRI1 mutation positive patient, and both by BICR. And secondary endpoint is OS. So if we see, yeah, please change the slide. Next slide. So if we see the baseline characteristics between both the arms, so well-balanced characteristics between both the arms. And next slide. So if we see the PFS by duration, like equal or more than 6 months, or equal or more than 12 months, and equal or more than 18 months, of patient who have received prior CDK4 inhibitor. So patient who has taken equal or more than 6 months of CDK4 inhibitor, the median PFS is 2.79 months in illustrated arm versus 1.91 month in SOC. And the patient was taken more than or equal to 12 months. The PFS is 3.78 months in illustrated arm versus 1.9 months in standard of care. And the patient was taken more than or equal to 18 months. And again, the PFS has increased. So basically, this PFS shows as soon as we goes towards patient who have responded more to CDK4 inhibitor. So response of illustrated is more in that subset of patient population. Next slide. PFS by duration. Patient was less than 6 months, 6 to 12 months, and 12 to 18 months of prior CDK4/6 inhibitor inhibition. So again, median PFS is 3.5 months. Illustrated was taken CDK4 inhibitor less than 6 months, and 1.87 months in the standard of care, whereas 1.91 months in illustrated arm. Patient was taken 6 to 12 months of CDK4 inhibitor versus 1.87, almost equal. Whereas in patient was taken more than around 12 to 18 months, the PFS is 3.52 months versus 1.84 months. Please change the slide. Next slide. So PFS by duration of prior PDK4/6 inhibitor in patient who has ESR1 mutation positive. ESR1 mutation is estrogen receptor mutation that makes endocrine therapy resistance in patient who has taken first or second line of endocrine therapy. So again, if we see median PFS with the duration of CDK4/6 inhibitor more than or equal to 6 months, 4.14 months, whereas standard of care 1.87 months. And as soon as we go towards more use of CDK4/6 inhibitor, we can see the increase in the PFS, like more than 12 months of CDK4/6 inhibitor, 8.6 months, whereas patient was taken more than or equal to 18 months. Again, PFS is more compared to standard of care. Again, if we see the PFS by duration less than 6 months, 6 to 12 months, or 12 to 18 months for prior CDK4/6 inhibitor in patient with estrogen receptor mutation. So again, we can see the patient was taken CDK4/6 inhibitor less than 6 months in ESR1 positive mutation. The PFS is almost same in both the arms. And if you see patient was taken 6 to 12 months, again the PFS is slightly better in the standard arm compared to standard of care. But patient who has taken 12 to 18 months of CDK4 inhibitor, the PFS and if we see the safety profile of this trial, so grade 3 nausea was around 2.5% of the population in last arm versus 0.9% in standard of care. And dose reduction due to nausea was around 1.3% patient population last arm, whereas standard of care not a discontinuation due to nausea 1.3% population in last one, whereas it was 0 in the standard of care. Antimatter use in 8% of the patient population in the last arm, whereas 10.3 in EI, whereas 1.3 in fulvestrant arm. And the 3.4% of the patient receiving Alestrant and 0.9% of patient receiving standard of care discontinued due to adverse event. And most adverse events were grade 1 or 2, and there was no grade 4 or 5 adverse events out there. No hematologic surface signals. There is no case of bradycardia. So this is all about Emerald trial of Alestrant, and that works in endocrine resistant patients who has received 1 or 2 lines of endocrine therapy, including CDK4/6 inhibitor. So next, moving to the next targeted therapy, which has also been approved recently, capivasertib. Next, change the slide. Next slide, please. Capitello 291, capivasertib plus fulvestrant versus placebo plus fulvestrant in EA-resistant hormone receptor positive, HER2 negative advanced breast cancer. So what is capivasertib? It is investigational oral inhibitor of AKT123 in combination with fulvestrant. It significantly prolonged PFS and OS in postmenopausal women with EA-resistant hormone receptor positive, HER2 negative ABC. In patient, no prior CDK4/6 inhibitor in phase 2 FACTON trial. So phase 3 Capitello 291 trial. Patient has been randomized between 2 arms. The eligibility criteria with main and postmenopausal women with hormone receptor HER2 negative advanced breast cancer, recurred or less than 12 months from end of adjuvant AI or progression of disease on prior AI, for and less than or equal to 2 lines of VT and 1 line or of chemotherapy, and no prior of SARD, mTOR, PIK3 or AKTI inhibitor, and HbA1c is less than or equal less than 8%, and diabetes not requiring insulin permitted. So it has been randomized between 2 arms, like capivasertib 400 mg BD, 4 days on, 3 days off, with fulvestrant 500 mg IV on day 1, day 50, every monthly, versus placebo with fulvestrant, same as in experimental arm. And the primary endpoint is investigator assessed PFS in overall population and in those with AKT pathway altered tumors. And secondary endpoint is OS and ORR response and AKT pathway altered tumor population. So if we see the baseline characteristics in both the arms, we can see the characteristics are well balanced between the 2 arms with capivasertib and fulvestrant. So if we see the next slide, please. So if we see the PFS in overall population, see the blue curve showing it separates as soon as it starts and reaches to 80%. Then it becomes separation, and we can see the well separated both the curves. And if we see the PFS in capivasertib with fulvestrant, it is 7.2 months versus 3.6 months in placebo plus fulvestrant with a hazard ratio of 0.6. Next slide. And if we see the PFS in AKT pathway altered population, so again PFS is almost same as per in all population, around 7.3 months in capivasertib arm versus 3.1 month in placebo arm, with hazard ratio better than previous in all population, like 0.5. And the study made dual primary endpoint showing significantly prolonged PFS with capivasertib with fulvestrant versus placebo. And the exploratory analysis of blood include PFS in non-altered subpopulation. So next slide. Next slide. If we see the forest plot, previous slide. If we see the forest plot, yeah, this one. So we can see the PFS subgroups in overall population. So PFS is better in capivasertib arm in all subgroups compared to placebo plus fulvestrant. Next slide. Next one. And if we see the response, so CR is in 1.1% population in capivasertib arm versus 0.2 population in placebo in overall population, and PR is in 19.2% population, whereas 10.8% population in placebo. And if we see the patient who was EKT pathway altered, so here we can see the CR is slightly better than overall population, 1.9%, and PR is slightly better than overall population, around 32.6% of the population. So overall response favored capivasertib plus fulvestrant. Next slide, please. So if we see the both Kaplan-Meier curve in OS, so here we can see the data has not matured and 28% of the data is mature. So we cannot assess overall survival. Next slide. So if we see the safety in overall population, so any adverse event like grade 1, grade 2, grade 3, 4, all adverse event 96% population, 6% population of placebo. Serious adverse event in 16% population of capivasertib, and any adverse event leading to death in 1% of the population in capivasertib. Any adverse event leading to discontinuation is 13% population capivasertib versus 2.3% population in fulvestrant. And any adverse event leading to interruption of capivasertib versus placebo, 34% in capivasertib fulvestrant versus 10% in placebo. Adverse event leading to dose reduction was more in capivasertib fulvestrant compared to placebo. And capivasertib plus fulvestrant, each of one patient has acute MI, cerebral hemorrhage, pneumonia, aspiration, and such.
Sir, request you to conclude your presentation in 2 minutes.
Yeah. So this is all about two recent advancement in metastatic breast cancer patient. A patient who was refractory to endocrine therapy, where we have opportunity to use the last trend in patient who was ESR1 mutation positive and patient who was taken CDK4 inhibitors, as well as we have another option of capivasertib in patient population was AKT positive population. So this is the recent advances, and in future definitely we'll use these two molecules in our clinical practice. Thank you.
Yeah, thank you, Prashant, for briefing us about the Emerald as well as the Captillo trial, and hopefully we'll see in the coming future these two drugs in the market, and hopefully, and with the virtue of this, we can help our patients in future. Yeah, thank you so much. So our next speaker is our dear friend, Dr. Sandeep Kukar. Yeah. Gitika?
Sir?
Yeah, please. Next speaker, please.
Sir, Dr. Sandeep Kukkar, sir, is the next speaker.
Yes. Yes. Our next speaker is our dear friend Dr. Sandeep Kukar, who is the head of the department at Sohana Super Specialty Hospital, Chandigarh, is in Chandigarh, and our dear friend. And so he will be briefing us about the tropics 2 and the tropics 2 and the STIC CTC abstract, recent advances in the carcinoma breast patients. So over to you, Dr. Sandeep. Dr. Sandeep, please share your slides.
Sir, next speaker is available. Dr. Shashank can Deepak, sir.
Yes, Geetika, please tell me. Yes.
Sir, Dr. Shashank sir is available. So अभी उनका टॉक
Okay,
करा
okay.
देते हैं. Dr. Sandeep शायद maybe is not
not an
available.
issue. So it's my honor and pleasure to introduce Dr. Sushant Mittal, who is our senior and associate director of medical oncology at Max Super Specialty Hospital, Shalimar Bagh, New Delhi. And he will be briefing us about the Destiny Breast 2 and the Destiny Breast 3 trial. Over to you, Dr. Sushant.
Thank you, Dr. Deepak. Am I audible?
Yes, sir.
Yeah.
Fine. So thank you so much.
Sorry to interrupt, Dr. Deepak. I'm so sorry. I was in the middle of some emergency. So I am back. Please allow me whenever you have time.
Okay, no problem. So after 10 minutes, your session will be starting, right? Is okay?
Yeah, sure. Thank you.
So I'll be talking about the HER2 positive breast cancer. We have two abstracts over here. One is a Destiny Breast 2, in which TDXT in HER2 positive metastatic breast cancer previously treated with TDM1, and the Destiny Breast 3, in which TDXD was compared with TDM1 in previously treated HER2 MBC. Next slide. So a lot of progress has been made in the HER2 metastatic breast cancer, yet there's an unmet need. We know that through the Cleopatra trial, that the dual anti-HER2 gave us the median PFS of 18.7 months, and patients progressing on this had an option of TDM1, which was proved through Emilia trial, in which median PFS was 9.6 months. However, still we are facing patients who do progress and are fit enough to receive third line or fourth line of therapy. And then this trial or the drug came, which is TDXG, in which the Destiny Breast 01 trial was done, which showed that the median PFS of 19.4 months was there, and it was a robust data in third line phase 2 single arm study, leading to regulatory approvals globally. So it was hence compared head to head with TDM1. Next slide. So TDXD was designed with 7 key attributes. TDXD is an antibody drug conjugate composed of 3 components: a humanized anti-HER2 IgG1 monoclonal antibody with the same amino acid sequence as trastuzumab, but covalently linked to topoisomerase 1 inhibitor payload, and a tetrapeptide-based cleavable linker. So a payload mechanism of action is topoisomerase 1 inhibitor, high potency of payload, high drug to antibody ratio of 8:1. Payload with short systemic half-life, stable linker payload, tumor selective cleavable linker, and a bystander anti-tumor effect in which not only it enters into the cancer cells, but also affects the cells which are nearby and hence killing those cancer cells as well. Next slide. So if we compare the TDXD with TDM1, the payload is topoisomerase 1 inhibitor versus anti-microtubule. The drug to antibody conjugate is 8:1 versus 3.5:1. Tumor selective cleavable linker, yes, it is present in TDXD, and evidence of bystander anti-tumor effect is also present in TDXD. So chemically and molecular level, it is better compared to TDM1. Next slide. So with this background, the Destiny Breast 2 trial was designed, in which trastuzumab deruxtecan in HER2-neu positive metastatic breast cancer after TDM1 was analyzed. Next slide. So patient with HER2-neu unresectable metastatic radiographic progression after most recent treatment and prior treatment with TDM1 was considered. 600 patients were there. They were randomized 1:1 into TDXD 5.4 mg per kg every 3 weeks versus physician choice. The randomization was not 1:1, but it was 2:1. And the data cutoff for TDXD was 21.5 months and physician choice was 18.6 months. And the primary endpoint being PFS and key secondary endpoint being OS. Next slide. So these baseline characteristics are well matched in both the population, the median age being around 54, with majority being less than 65. Asian population was 1/4 of the total population. Majority were obviously HER2-neu positive. HER2-neu 2+ was in about 19% of the patients. And ECOG performance status 0 to 1. However, we would like to know the data for ECOG performance status 2 also, because in clinical practice, we do get such kind of patients. Hormone receptor positive patients were about 58%. And brain metastasis at the baseline was present in about 18% of the patient. Next slide. The prior lines of treatment, if you see, majority had received either 2 or 3 lines, but about 8% of the population did receive more than 5 lines of prior therapy. Median prior lines of therapy was about 2, and prior lines of therapy was trastuzumab, TDM1, taxanes, pertuzumab, which are well balanced between these two arms. Next slide. So the PFS data, if we see for TDXD, it is 17.8 versus 6.9 with a hazard ratio of 0.35 and significant p-value. So 10.9 months of PFS benefit is there. At the end of 1 year and at the end of 2 years, there is the benefit which continues to sustain. And the median overall survival benefit is, absolute benefit is 12.7 months, which is almost 1 year. So in physician choice of patients, 69% of the patients received new systemic anti-cancer therapy and 25% received TDXD in the post-trial setting. So PFS superior with TDXD across all SS subgroups, including among patients with baseline brain metastasis. Next slide. The secondary endpoint, which was overall survival and the response rates, 14% of the patients did achieve complete remission even after 2 to 3 lines of therapies with prior anti-HER2-neu. Median duration of response was about 20 months. And the median PFS, as I told you, was 16 months versus 5.5. And median PFS 2 is 35 versus 15 months. So in all aspects, TDXD edged over the physician's choice of treatment. Next slide. The safety summary. This drug does have its side effects, but they are manageable. The drug-related side effects are higher with TDXD, and the interruption of the treatment because of drug relation was almost similar in TDXD and physician choice of treatment. Next slide. Previous slide, please. So TDXD, the most common drug-related side effects was pneumonitis in about 6.2% of the patient, out of which ILD was present in 3.2%. And in the physician choice of drug-related side effects was Palmer-Plantar erythrodysesthesia in about 1.5% of the population. Next slide. So most common side effects are anemia and decreased neutrophils, but these are manageable. Next slide. So adverse events of special interest are ILD and LV dysfunction. In about 4.5% of the population had this LV dysfunction. However, the grade 3, which is significant LV dysfunction, was present only in 0.5% of the population. Next slide. So to summarize for Destiny 2, TDXD significantly improved PFS and OS compared with physician choice in patients with HER2 positive metastatic breast cancer. The reduced risk of progression or death was there with median PFS of 17.8 versus 6.9 months. Reduced risk of death 39 versus 26 months, and no new safety signals were observed. Next slide. So with this background, the Destiny Breast 3 trial was designed, in which TDXD was directly head-on compared with TDM1. Next slide. So patient with unresectable or metastatic HER2 breast cancer previously treated with trastuzumab or taxanes in metastatic setting or adjuvant therapy with recurrence in less than 6 months with good performance status. 500 patients were there, in which TDXD again was compared with TDM1, and the median follow-up was 28 months versus 26 months. Next slide. So baseline characteristics were well balanced. Again, the median age was about 50 months. Females were obviously majority were females, and the Asian population was about 57% were represented. HER2 data was available in 90%. ECOG performance status was 0 to 1. Again, 50% of the population was hormone receptor positive. So in triple positive patients also, this data can be used and the drug can be given in such category of patients as well. Brain metastasis in about 16%, with visceral disease 70% of the population. Next slide. So we can see this remarkable graph in which the updated PFS shows that the graphs start separating within 1 or 2 months and continue to do so even at the end of about 2 years to 3 years. The median survival was 28 months versus 6.8 months in Destiny 03 trial. Next, next slide. So updated OS, although the graphs are taking some time to separate, but both the drugs have not reached the median. However, whatever data is available, the hazard ratio seems to be favoring TDXD, and it is 0.64. So about 36% of the patients we are able to delay the death in such kind of patients. Next slide. So subgroup analysis, as I told you, in all category of patients, whether hormone positive or negative, previous pertuzumab, received, not received, visceral disease, previous systemic lines of therapy less than 3, more than 3, and baseline brain mets. So in all category of the patients, this data favors TDXD. Next slide. In the waterfall graph as well, we can see that the area is much more higher. The more number of patients are responding, and we can see in the data that the 21% of the patient had CR even after 2 lines of or previously treated HER2 positive metastatic breast cancer. So this is unheard that 21% of the population does have CR with TDXD, which is remarkable. Next slide. Overall safety, again, the rates of drug-related grade 3 side effects were similar between the two arms, and the pneumonitis was 5.8% with ILD 5.1 and pneumonia being 1.9. With TDM, it was decreased platelet, which is about 1.5%, pneumonitis in 1.1, and thrombocytopenia in 1.1% of the population. With longer treatment exposure, the rates of ILD increased from 10.5 to 15.2. So one has to have a high index of suspicion if the patient has breathlessness. Is it because of the disease? Is it because of increase in meds, or is it because of the ILD? Next slide. Next slide. So TDXD demonstrated significant overall improvement with 36% reduction in risk of death compared with TDM1 in patients with previously treated HER2 positive breast cancers, and overall survival benefited across all the patient subgroups. Updated results further support the use of TDXD as second line standard of care in HER2 MBC. Next slide. So that's why in ESMO as well as NCCN guidelines, both have included TDXD as the second line and TDM1 in the later line settings. Next slide. Thank you so much. Back to the organizers.
Yeah, thank you, Dr. Sushant, for enlightening us regarding the new molecule. And the time is not far that we will be using in the second line this molecule. Yeah, now our next speaker is our dear friend Dr. Sandeep Pukar. He's the head of the department in Sohana Super Specialty Hospital. And so he will be briefing about the topic 2 abstract and as well as the STIC CTC abstract. Over to you, Dr. Sandeep.
Good evening, everyone, and apologies for joining late for today's session. So please, can somebody share the slides on my behalf?
Sir, I already shared.
So do I have a control, or you'll be like moving the slides?
Can I share your remote control, your access?
So I think we can go ahead. So we have two topics for discussion today. One is sacituzumab govitecan versus the investigator choice in ER positive HER2 negative MBC. So this was a topic 2 study which was presented in the recent ESMO, as well as there was an abstract in SABCS as well. So basically, we know that sacituzumab govitecan is an antibody drug conjugate which has been tried in various types of breast cancer, and particularly gain importance in triple negative breast cancers, and has been tested in ER positive HER2 negative MBCs. Important fact to remember that this molecule has also been updated in the recent NCCN guidelines as a treatment in a heavily pretreated patients post the use of CDK4/6 directed therapy. Next slide, please.
Sir, you can access from your side.
But it's not moving. It's not moving. Yes. So the background is HR positive and HER2 negative is the most common subset of metastatic breast cancer. And we know that apart from the sequential use of various endocrine agents, the only thing that is left over is the use of either dual versus single agent chemotherapy once a patient has progressed over various endocrine treatment options. So this is a new molecule, sacituzumab govitecan, which is anti-TROP2 antibody drug conjugate, approved for metastatic triple negative breast cancer with more than 2 prior therapies with impressive overall response rates. This was again in the phase 1 and 2 study. This was tested in HR positive, HER2 negative MBC cohort, demonstrating an objective response rate of around 31% with a median PFS of around 5.5 months and an overall survival of around 12 months with a manageable safety profile. Next slide, please. So basically, TROP2 is a transmembrane calcium signal transducer, which is highly expressed in MBCs, and it plays an important role in tumor growth and progression. Sacituzumab govitecan is a novel antibody drug conjugate, which, as we know, that has got a payload that is SN38, which is you can say the molecule, the active moiety of irinotecan, the active metabolite of irinotecan via the use of a unique hydrolyzable linker. So the linker is this is the pH dependent mechanism where the linker is hydrolyzed and the payload is released, which apart from having the internalization and the release of sacituzumab govitecan, the active moiety, it also has a bystander effect that leads to the active killing of the tumor cells, not on the surface, but as well as within the tumor. Next slide, please. So this was the trial design where you can see HR positive, HER2 negative breast cancer cases which have progressed on more than one line of endocrine therapy, taxane, CDK4/6 inhibitor in any setting, 2 to 4 lines of therapy. So at least 2 and maximum 4, they were included in this trial design. Sacituzumab govitecan was given 10 milligram per kg, day 1, day 8 in 21-day cycle versus the physician choice of treatment, which was capecitabine, vinorelbine, gemcitabine, or eribulin. The primary endpoint was progression-free survival. Secondary endpoints were various like overall survival, duration of response, clinical benefit rate, safety signals. Next slide, please. So again, an exploratory analysis was also carried out depending on the H-score, which was the calculation of a scoring system depending on whether we could have any biomarker depending on the expression of TROP2 on the surface. So the baseline clinical characteristics were very well matched between the two arms. And you can see here that prior CDK4/6 use less than 12 months versus more than 12 months. You can see here 55% had the usage of CDK4/6, and the median number of lines, if you see, 66% of the patients had already received 3 to 4 lines of treatment regimens. So this was basically a very heavily pre-treated population in which this molecule has been tested. Next slide. So the results were impressive. PFS difference of around 1.5 months, 5.5 versus 4. 12 months PFS rate of almost the tripling of the 12 months PFS rate, 7% versus 21. And an improvement in the median OS as well, 13.9 months versus 12.3 months, close to approximately 2 months of an overall survival difference in a population which is actually heavily pre-treated, and majority of the times we have only a single agent of chemotherapy that can be offered to this kind of patients. Median duration of response was also impressive, around 7.5 months versus 5.6 months. Next slide. Adverse effects, again, very well manageable. Neutropenia, diarrhea, discontinuation rates were almost very similar between the two arms. Next slide. Depending on the H-score, TROP2 expression was determined on a primary as well as metastatic archival tumor tissue by IHC and was expressed as a H-score ranging from 0 to 300, and efficacy outcomes were assessed between less than 100, more than or equal to 100, and it was further subdivided into less than 10 versus 10 to less than 100. But as we'll see in the coming slides, next slide please. As we see in the coming slides that if the H-score is high, the benefit is more. If the H-score drops to less than 10, the benefit goes down. The hazards, if you can see in less than 10, it is 0.89 versus if the hazards of around 0.6 if the H-score is more than 100. But in the overall intent to treat population, if you see overall benefit, it does not make a difference whether you have score less than 100 or more than 100. But still, we do not have you can say, it is not a perfect biomarker, or it is not the perfect deadline. You can say that beyond a which score the drug should be actually recommended. So depending on the H-score, the recommendation is you can use the molecule depending on whatever irrespective of the H-scores. Next slide. So again, the benefit is almost the same. You can see here ORR, there's not much of a difference, only the population which is very high H-scores, they do pretty well compared to the other two arms. Next slide. So conclusion, it provides a clinically meaningful significant and clinically meaningful PFS benefit over the single agent chemotherapy with a very well manageable safety profile. Exploratory analysis confirmed the efficacy of this molecule, sacubitril govitecan, across all TROP2 expression levels, irrespective of the expression of the H scores. And the investigators finally concluded that TROP2 testing is not required for giving or administering treatment for this molecule. Next slide, please. So we move on to the second topic, which was again presented at the San Antonio Breast Cancer Symposium in 2022. Very recent article, because we all know that the use of circulating tumor cells as a prognostic biomarker has been extensively studied in the last 2 decades, and it has been demonstrated that there is some clinical utility of this molecule as a biomarker, and depending on this, CTC count could drive and could help us make difficult treatment decisions between whether to escalate the endocrine therapy or chemotherapy in a population depending on the high circulating tumor cells. So this was a study which was presented by Bidard and colleagues, which designed the study depending on the CTC circulating tumor cells, where approximately more than 700 patients were randomized between the investigator choice of treatment versus their treatment depending on the CTC or circulating tumor cell count. So this is basically the backdrop of the trial, that design that we are going to study, that is the clinical validity of CTC as a biomarker. The seminal demonstration with a CTC of 5 cells more than 7.5 ml or greater was associated with a shorter OS and PFS, and this prompted its clearance by US FDA for the clinical use of prognostication. CTC again later reached a level 1 of evidence as a prognostic marker in the pooled analysis of more than 1900 patients in MBC. Multivariate analysis again confirmed 3 prominent prognostic markers, that is tumor subtype, performance scale, and the baseline CTC count. So this result suggested that the population that is HR positive, HER2 negative is with homogeneous performance scale, baseline CTC, may be a more reliable, standardized, and reproducible prognostic marker than other characteristics commonly used by clinicians to drive their treatment decision making. Next slide, please. So the anticipation was that most of the patients would not have their treatment unchanged, while some of the patients might be escalated from endocrine therapy to chemotherapy, or some might be de-escalated from chemotherapy to endocrine therapy. So this is basically HR positive and HER2 negative population with the use of either endocrine therapy or chemotherapy depending on their CTC count versus the investigator choice of therapy, and the primary endpoint was a non-inferiority trial design. Next slide, please. So basically, more than 700 patients were randomized, and the primary analysis in SABCS was done in 2018, which showed a PFS benefit, and then this trial design was escalated to have further look in 2022 for the overall survival and the escalation or de-escalation of therapy. And after nearly around a 5-year of follow-up from 2018 to 2023, we can see the overall survival analysis of the trial in the coming slide, and the recommendations, the discordant recommendations, I would say, between the investigator choice of therapy and the depending on their CTC count. Next slide, please. So you can see here there are 4 different cohorts: clinically low, clinically high, CTC low, and CTC high. And they have been prescribed endocrine therapy, chemotherapy, endocrine, chemo. So overall, this has been analyzed in an overall perspective of a clinically low, tumor low, clinically high, tumor high, clinically low and tumor high, clinically high and tumor low. Basically, 4 parameters have been studied. Next slide, please. So you can see here overall survival results in all the population. It did not make a difference. The curves are almost overlapping each other. The PFS with a hazard of 0.94 and OS 0.85. So this trial definitely demonstrated a non-inferiority previously demonstrated for PFS in 2018, and longer follow-up showed that CTC guided treatment, it remains safe, that it is non-inferior to what the standard treatment that we have been following over decades. Next slide. But if you go further, in a population which is this is clinically low, I think this is almost again the same, which has been concordantly seen in the investigator choice versus the CTC based treatment. The curves are almost overlapping each other, and this was almost a 50% of the population where the choice of treatment did not make a difference depending on the circulating tumor cells. Next slide, please. But amongst this, there is a 25% subset of population where for whom the endocrine therapy was recommended. The endocrine therapy was recommended as a treatment by investigator choice, but who had a high circulating tumor cells. Then those who were treated with chemotherapy, this demonstrated that they had an absolute difference of approximately 16 months in the median overall survival, you can say, and 47% reduction in their risk of death compared to the population who received the endocrine therapy. So you can see here, this is the one subgroup which definitely needs to be highlighted in a way that this is a population which is clinically low and CTC high, where the endocrine therapy seems to be inferior compared to the investigator choice of therapy, with a significant difference of around 16 months. Next slide, please. So from overall learning of our perception of low versus high, we also come to a population which is approximately 13%, where clinically it is high and CTC it is low. You can see here that the endocrine choice of therapy, it again has to be de-escalated in a population which is having CTC low, which is again doing very similar to the chemotherapy arm. So there is a certain subset of population which can be tried depending on their circulating tumor cell load and the choice of therapy accordingly. Next slide, please. So you can see here that the meaningful survival benefit that we have seen is clinically low and CTC high, where the treatment recommendation from the CTC based arm actually makes a difference. So this is one of the first study which has highlighted, which is the first one to establish the utility, the clinical utility of circulating tumor cells as a biomarker in breast cancer, indicating that a single assessment, even a single assessment of circulating tumor cell before the start of treatment, can guide your treatment decision making between the chemotherapy and a single agent endocrine therapy, and can be taken forward as a marker of prognostication as well as prediction of your therapy. So there is definitely a subset which can be highlighted depending on their circulating tumor cells. Next slide, please. So limitations, that this slide was, as I already told, the first analysis of PFS was in 2018, but the study was well beyond the conducted study before the era of CDK4/6 inhibitors that are now the standard of care. So definitely this is the one main limiting factor, that this has not included one of the major standard of treatment that we have incorporated in the today's armamentarium of treatment for HR positive cases. So cell search system is the only FDA approved CTC based detection technology for MBC. Next slide, please. So as I already told that this is one of the first prospective trial that supports the clinical utility. Basically, the utility is only for CTC high versus clinically low. Next slide, please. So I thank you for Dr. Deepak for providing the opportunity, and thank you organizers for giving this platform to share some meaningful information on this platform. Thank you.
Yeah, thank you, Dr. Sandeep, for enlightening us. It's an eye-opener for the circulating tumor cell. I just have one question to you, Dr. Sandeep. Am I audible?
Yes,
Sandeep?
Dr.
So
Deepak,
in your
please go
practice,
ahead.
in which cases you are doing CTCs? Like in which cases you are doing CTC? Are you doing it or not?
No. I think as far as clinical application is concerned, we do not have any standard test that can be applied in our clinical day-to-day practice. We do not have any test that has been recommended, as has been recommended by FDA in any of the labs that are available in India.
Okay. Thank you so much, Dr. Sandeep.
Thank you.
Yeah. Today's now we have coming to the end. So now our today's last speaker is our dear friend Dr. Chitresh Agarwal, who is a senior consultant and unit head at Paras Hospital, Panchkula. So he will be talking about his experience on the FESGO, which is a combination of pertuzumab and the trastuzumab. As we know that we are moving ahead towards the daycare practice, in which we admit the patient and immediately, within the few hours we can discharge the patient. So Dr. Chitresh will be talking about his experience about FESGO and how does it work. Doctor, over to you, Dr. Chitresh.
I'm not able to share the slides. You cannot start. I request Gitika to please allow me to share the slides.
Yes, sir, you can.
Are they visible?
Yes.
The topic is transforming the journey for HER2-positive breast cancer patient. So we know that this Perjeta Herceptin combination is now a standard of care for most of the settings. We know of the neoadjuvant, adjuvant, and metastatic setting. We know the trials Neosphere, Affinity, and Cleopatra. And we have seen that this combination, in neoadjuvant setting, it adds to the PCR rates. In adjuvant setting, it gives benefit in node-positive patients. And in metastatic setting, it has, increase in the PFS and OS. So this combination, along with chemotherapy, is approved and recognized by the international guidelines as the standard of care for patients who are HER2-positive breast cancer. Now, we know this chart very well. Multidisciplinary tumor board discussion about a breast cancer patient which is HER2 positive. We decide on whether the patient is to be offered neoadjuvant or upfront surgery. Generally, if a tumor is more than 2 centimeter or node positive, we offer neoadjuvant chemotherapy followed by surgery. And then depending on the histopathology report, we see what is the level of residual disease or whether PCR has been achieved or not. If yes, we continue the same one. If not, we switch over to TDM1. Very selected patients who are clinically T1 and node negative, they offer direct upfront surgery, and then if they are node positive, we offer this pertuzumab or trastuzumab combination. Otherwise, only trastuzumab plus single agent paclitaxel. Now, this IV infusion of these monoclonal antibodies, the problem is longer infusion rates, challenges of improving resource utilization, placement and maintenance of indwelling venous catheters, and challenges of venous access in some patients, especially patients who are on chemotherapy along with all these agents, and they make establishing the IV lines a very big challenge. FESGO is the first formulation in oncology to combine two monoclonal antibodies, pertuzumab and trastuzumab, in one vial for a subcutaneous injection, which contains the same antibodies as approved for IV combinations, but has a different route of administration. It is formulated with recombinant human hyaluronidase to allow subcutaneous administration to a higher drug volume, because we know that 15 ml is the loading dose and 10 ml is the maintenance dose. And we will see in the subsequent slides that how 10 ml subcutaneous doses have been made. And it is a ready-to-use fixed dose formulation administered by a single subcutaneous injection in the thigh. Now, what is the mechanism of action? We know that pertuzumab and trastuzumab fixed dose combination for subcutaneous use. We have a two monoclonal antibody combination, and it is recombined with human hyaluronidase. What it does is that it is designed to work with trastuzumab for a dual HER2 blockade. And hyaluronidase is actually an endoglycosidase, which is used to increase the dispersion and absorption of co-administered drugs when they're administered subcutaneously. So what happens is that hyaluronidase allows large drug volume. It increases the permeability of the subcutaneous tissue. By depolyct of this hyaluronidase is reversible, and the permeability of the subcutaneous tissue is restored within 24 to 48 hours. So, subcutaneous layer contains a matrix of hyaluron fibers and collagen fibers, which limits this subcutaneous administration to usually less than 1 ml. But this addition of recombinant hyaluronidase to FESGO temporarily and locally degrades hyaluron at the injection site. And this degradation of hyaluron actually results in the temporary increase in the local subcutaneous dispersion of the area, enabling a large volume of fluid administration. And this is reversible, as we have discussed, and this allows for formulation to allow subcutaneous administration of large volumes, which are far more than 1 ml. As you see these two, because you will be able to appreciate that if a patient is given subcutaneous injection without the help of recombinant hyaluronidase, you will see that swelling, that induration that is seen. But after 2,000 units of per ml recombinant protection, we know that there has been no induration or there has been no difficulty in the subcutaneous administration of a 10 ml injection. So does Phesgo has the same pharmacokinetics, efficacy, and safety as the IV formulations of pertuzumab and Herceptin or trastuzumab? So the Phesgo clinical development program was a well-studied one. We have phase 1B, phase 2, and phase 3 studies about this development. We will not go into the details of this, but I will just go to the summary. It shows that selected loading dose of 1200 milligrams pertuzumab subcutaneously and a maintenance dose of 600 milligrams pertuzumab was used in Phesgo, and the dose finding process used to find the subcutaneous dose of pertuzumab was similar. No new safety signal was observed, and the pharmacokinetic and safety results supported the further development of Phesgo. Then came the Federicia, which was a phase 3 non-inferiority study assessing the pharmacokinetics, efficacy, and safety of subcutaneous versus IV formulations. The pharmacokinetic parameters were important for understanding the bioequivalence between the IV and the subcutaneous formulations. And what we, concluded from this was that the incidence of adverse events were consistent between the arms. Incidence of adverse events of on all the functions, with the diarrhea, neutropenia, cardiac dysfunctions, they were more or less same and they were comparable. There was no meaningful difference in cardiac safety. What it showed was that the subcutaneous form was non-inferior to the IV form. It had a comparable efficacy and safety, and this was non-inferior and equally effective and very safe. So patients prefer subcutaneous formulation to IV formulation. This was the Francisca study, which evaluated a phase 2 study studying the assessing patient preference to IV versus subcutaneous. And if you see the results, you will be astonished to see that most of the patients actually preferred the subcutaneous preparations, and the difference was very high. It was 88% versus 13%, 80%, 15%. So this was the a very, very encouraging thing for the patients to have a subcutaneous formulation. And the majority of the reasons for opting subcutaneous route was less time in clinic and more comfortable during the administration process. And 87% chose the subcutaneous preparation to continue instead of the IV preparation. We all were satisfied, very satisfied with the subcutaneous preparation. And the majority of the physicians and the healthcare providers felt that switching from IV to subcutaneous would save both the time and the resource. So adverse events were similar with no new safety signals. And as I previously mentioned, main reasons were less time in clinic, patient satisfaction, and more comfortable during drug administration. So what are the practical considerations for using the Phesgo in the real world? We all know that there are some tips to ensure comfortable drug delivery. We have to make a particular position for a patient. The injection site should be alternated between left and right thigh only. It should never be administered in the abdomen. Do not split the dose between two syringes or between the two sites of administration. And each new injection should be given at least 2.5 centimeters away from the previous site. And we have to choose a healthy skin that is not red, bruised, tattooed, tender, or hard. And we have to record the use site on the patient's notes. Now, 30-degree angle has to be made for injection, and then we have to place this drug and give it off. The injection should be slowed or paused if the patient experiences a significant injection-related reaction. Make sure that medication, to treat reactions as well as emergency equipment is available. And after the loading dose, the patient should be observed for a minimum of 30 to 45 minutes for signs of any hypersensitivity or administration-related reactions. And after the maintenance dose, the patient should be observed for a minimum of 50 minutes. Now, depending on the hospital's outpatient settings, the doses can be administered on a dedicated rate. If the drug is administered in the chemotherapy day unit, curtains or other shades are required to ensure patient privacy, and nurses should have comfortable chair and a removable drug table to ensure quality and safety of administration. What could Phesgo mean for patients and the healthcare providers? Phesgo provides benefit in cost, benefit of time and reduction of the patient HCP burden. It is a fixed dose formulation. It is subcutaneous. It is shorter time of administration. No new safety signals, and it is very comfortable to the patient to have a subcutaneous preparation. So, to summarize, Phesgo is the first formulation in oncology to combine two monoclonal antibodies. Phesgo has cycle 7 Phesgo and 8 serum concentration incidence of adverse events comparable to IV ones, and the PCR rates were almost identical between the IV and the subcutaneous formulation. Majority of the patients, they preferred subcutaneous forms, and it is now FDA and EMA approved for the same indications as the IV formulation.
Yeah, thank you, Dr. Chitresh, for enlightening us regarding the Phesgo, and it's a new one, subcutaneous formulation. So what is your experience with Phesgo? I mean, I have never used it because I asked for one CGHS fellow, but they didn't issue that. I mean, what is your experience? Are you using in Paris?
So we have used a couple of patients, and the reaction has been, comfortable. Patients prefer subcutaneous preparation. But one of that patient, they had a progression. We shifted from subcutaneous to IV, and the same patient actually had a remission or a control again. So we don't know whether it was the difference in administration, or we were new in administrating this drug, or what happened. But now the patient is doing on IV formulation of these two drugs.
Okay, right. Thank you so much, Dr. Chitresh, for sparing
Thank
your
you.
valuable time. Yeah. Geetika, am I audible? Yes, sir. Yeah, I thank all my participants for sparing their valuable time on this Saturday evening, and for enlightening us new advancement in molecular biology, and the new advancement in the HER2 positive as well as the hormone positive breast cancer, and the new formulation about subcutaneous preparation. In future, and it was a great opportunity to interact with all the participants and all my dear friends. And thank you, the organizer Horizon, for conducting this webinar. So thank you all, and good night.
Thank you, sir. Thank you, everyone, for joining for us for the 2 days webinar, a great academic feast. Thank you, everyone. Thank you to our academic partners. Thank you, sir. Good night, everyone.